In today's video, we are going over abstracts from ASCO GU. That stands for the American Society of Clinical Oncology, and this specific meeting is for genitourinary diseases. They cover things like kidney, bladder, a couple others, but they also cover prostate, and that's a large part of it. There's researchers from all over the world who come in and show their data. Some are looking at old registries, some are looking at older sets of data, and some are looking at new clinical trials, but it's very interesting as far as research goes, and it really shows us where prostate cancer treatments could be going in the future, talking about side effects, all sorts of interesting details when it comes to prostate cancer. So today we're going to talk to Dr. Mark Schultz. He's a 30-year medical oncologist who is solely focused on prostate cancer, and he's going to discuss the abstracts that stood out to him. So the first abstract we're going to go over is number 310, and it's not that that's the first abstract. There's hundreds if thousands of abstracts that are submitted, but this one was quite interesting. And it deals with testosterone recovery. So can you go over the abstract and kind of explain it to us in layman terms, especially as far as how clinical trials work with these things?
Sometimes the researchers have a lot of data from an older trial, and one of the things in prostate cancer, because it's a slowly evolving condition and men may live 10, 20, 30 years after the initial study, they can learn more as time unfolds. And so they revisited the data from a study done many years ago where they were trying to answer the question, when you have high-risk prostate cancer and you're having radiation, should you have a year and a half of hormone therapy or should you have 3 years of hormone therapy? We already knew the answer is that a year and a half is just as good as 3. Going beyond a year and a half, you're just accruing more side effects. But that's not the point of the particular study that was done. They looked at several factors. Number one, if you have that duration of hormone deprivation, how many men ultimately, since they have long follow-up now, recover normal levels of testosterone when they stop? And it turned out in the men that had a treatment period of 18 months, only half of the men recovered their testosterone back to normal levels. And in the men that had 36 months, 45%, so slightly less than half of the men recovered their testosterone levels back to normal levels. That's an interesting observation right there, the fact that so many men are left with unrecovered testosterone. They also looked at another important factor, which I'm sure you're already wondering about. If you didn't recover testosterone, in other words, you're almost on lifelong hormone blockade, or you did recover testosterone, was your prostate cancer mortality rate different in those two groups? And the answer was it was not. So going beyond even longer periods did not improve survival. And so there was no advantage to having your testosterone not recover or recover after the treatment was stopped. The most interesting thing about this particular review of this older data was that the men who recovered testosterone had better overall survival compared to the men who didn't recover testosterone. Does that mean that testosterone somehow makes you live longer? I somehow suspect probably not. I think what it means is that the men whose testosterone recovered were more robust and healthier. That would be my guess. Not that the testosterone itself gives you longer or shorter survival. But the reason I wanted to present this particular information is because I have, as you can see, half the men that go on long-term hormone therapy are running around with low testosterone levels for the rest of their lives. And in many cases, they're quite frightened or nervous about taking testosterone to recover their normal sense of well-being due to concerns about the cancer coming back or maybe facing early mortality. So this is a beautiful trial that addresses that question very clearly and very directly, that if men are running low testosterone levels, there's no evidence that starting on testosterone, as long as you're being monitored appropriately, would cause a detrimental issue with survival related to prostate cancer.
So in abstract 352, which again we're going to link in the comment section, it deals with a really awesome finding that I think it's kind of known nowadays because you've talked about spot radiation and metastatic lesions around the body and spot radiation being able to cure patients. But it's really cool that we're able to see this in an abstract where they're talking about metastatic lesions that have gone to the lymph nodes and the cure rates even with high Gleason scores. So can you speak more to this?
Historically, especially with other cancers, if there's any metastasis, the word cancer means that those people are going to succumb to the disease, that you've lost the war and you may be able to fight rearguard action for a while, but once it spreads, then it's going to be fatal. This, of course, mindset is in the back of people's minds when people are diagnosed and the doctor says, yeah, it looks like it has spread to the lymph nodes. This particular abstract addresses 5-year disease-free survival, which is approaching what we would consider a cure, in men that had high Gleason scores 8, 9, 10, and known lymph node disease when they embarked upon treatment with radiation to the prostate and the lymph nodes and ancillary hormone therapy, which is standard approach. What is the likelihood of 5 years later, after all treatment is finished, of not having the cancer come back, being in a complete remission, possibly being cured? And they found in this particular abstract that if you had a Gleason 8, 5-year disease-free survival was 71%. Well over half of the men are in complete durable remission. If the Gleason score is 9 or 10, it was slightly lower at about 60%. This is very optimistic, and I want to go one step beyond this because in this modern era, men that are not cured are not necessarily ever going to die of prostate cancer. So we're watching these. You say, well, if it's 71%, now you've got 29% that are having a relapse. So what happens to those 29%? Well, that's not addressed in this article, but use of PSMA PET scans and other developments are also offering a lot of optimism, even for the men that aren't cured. But the idea of one and done, truly shutting the door on high-grade early metastatic prostate cancer is, I think, very exciting.
Well, I think it's a point that we reiterate a lot on the channel, but it's extremely important, is it really matters at what point you catch the cancer. And so I think a lot of people, when they say, well, I have a much more aggressive cancer, I have higher Gleason scores, and I have metastases all over the body, that's a very different situation from somebody who has, lymph node metastases and they're curing it with spot radiation. In those situations, it's a completely different ballgame. And according to the American Cancer Society, it's not our statistics, it's the American Cancer Society is saying that you have a 5-year 99% survival rate. So I think this type of data is really exciting, confirming that, PSA screening is so important. You want to make sure to get, early in on those checks and encourage your friends and other people, family members to get them, because with these type of survival rates, even aggressive cancer can be cured.
That's right. And it's quite obvious on the face of it, but it's nice to mention that if we're getting these sorts of cure rates with high Gleason metastasis to lymph nodes, imagine how much better the cure rates are now that we're finding, even men with high-grade disease, Gleason 8, 9, 10, who have PET scans that show no spread. So we're going to certainly expect that those people will have far better cure rates than we would see with someone with known lymph node disease.
Before I get to my next question, I just wanted to remind you that in September we have a prostate cancer patients and caregivers conference in person here in Los Angeles, and it's a great way to get your questions answered by world-renowned prostate cancer experts all in one weekend. You can learn more at pcri.org/conference. Now also click that subscribe button because it's a great way to support the work we do here at PCRI and get our videos out to other prostate cancer patients who need help. And if you'd like to support us financially, you can do so at pcri.org/donate. Now back to my conversation with Dr. Schulz. So now we're at Abstract 382, and the two big players when it comes to treatments in prostate cancer is surgery and radiation. Many men just go get surgery without even knowing their Gleason score. A lot of times they're just doing what the urologist says. It's not the urologist is a bad guy. It's just that's how the system works. And then sometimes they hear, you can do radiation later, but the timing of all of that and how the PSA works and how the cancer is acting after radiation does matter. So can you speak to this, abstract and what it's talking about regarding the timing of PSA rising after surgery?
So historically, especially when we didn't have PET scans, the general feeling was pretty much any rising PSA that was steadily rising should be treated empirically with radiation to where the prostate used to be. And you could cure a certain number of men that way, which is really cool. It is associated with a slightly higher risk of making erectile dysfunction worse and incontinence worse, but that was the trade-off. This particular study looked at long-term survival rates, the development of metastasis in men who did or didn't have radiation at different junctures, at different echelons of PSA. One thing that they found was that administering radiation empirically at the get-go when the PSA is really low, say less than 0.4, did not provide a lot of difference in long-term outcome. And the endpoint that they use is say, well, how many men do you have to treat who don't benefit? What is that number to have one person that either has fewer metastasis or better survival rate? So in this particular trial, they had to treat 15 men who didn't need it. In other words, they didn't see any difference in the incidence of metastasis, and they had to treat 25 people to see a reduction in mortality. That's 25 people that didn't need the radiation that would have had the same outcome if they hadn't had the radiation at that early juncture. This data, I think, is a strong suggestion for people who are facing rising PSAs after surgery to consider waiting and doing PSMA PET scans to find the site where the cancer is. We don't know for sure that it's right where the prostate used to be. Remember, we're empirically administering radiation to that area on the thought that that's the most likely site because it hasn't been seen. What a difference if the disease can be localized specifically with a PET scan, and then the radiation can be directed where the known cancer is. That policy, at least waiting till the PSA rises up to 0.4, appears to be a very safe method to follow.
So a couple of factors. I don't think a lot of people realize that they can get spot radiation after surgery, because when we think about radiation, we kind of think about to the whole bed of the prostate, as you said. So it's kind of an interesting thing if you have, a lymph node or another spot that you can get spot radiation. But when it comes to the PSMA scan, what level of sensitivity does the PSA need to be, or what level of PSA do you need to have in order for the scan to be sensitive enough to pick it up?
A good rule of thumb is when you're in this situation and ordering a PET scan, you can sort of look at the PSA when it's under 1 as sort of a percentage likelihood that you'll find it. So with a PSA of 0.4, there's probably a 40% chance that you'll find it. With a PSA of 0.9, you're about a 90% chance that your PET scan will show where the disease is. Naturally, people are nervous about postponing treatment. You can see the PSA going up over time. If it's going up more slowly, that's reassuring. If it's going up more quickly, that's a little nerve-wracking. That push-pull between how much ground am I losing by waiting when the PSA is rising, rather than just jumping in and treating, versus how much ground do I gain if by waiting I find where it is and I have more specific and directed treatment, which is certainly more likely to be effective.
So with Abstract 137, they're looking at these really large clinical trials that were used in order to approve hormone therapy drugs. And in one of the trials, they had over 2,000 patients, and 1/4 of them were on statins, which are cholesterol pills. So there's an interesting correlation there. Can you talk about what statins do, and also what the difference in survival was when it came to these clinical trials?
So for some time now, there have been database studies suggesting that men who are undergoing radiation or who have prostate cancer have better long-term outcomes when they're taking cholesterol pills. People have speculated as to why this might be the case. We do know that diet matters, and that these pills, in some sense, are sort of a shortcut to the appearance of a better diet when they lower cholesterol levels. That may be the mechanism, but this study, 500 of the patients happened to be taking statins. They weren't allocated to it, but again, we're doing a retrospective review of a previous randomized prospective trial, looking at survival rates. Quite simply, if the men taking statins had better survival rates than the men who weren't taking statins. And it turned out that they did. This, as I said, has shown up in other database studies as well. People are speculating as to why it might be the case. There's been some studies where the statins haven't shown a clear-cut advantage. There have been studies where large groups of men have undergone radical prostatectomy. They looked at, did the patients who were taking statins do better? And they didn't show different outcomes, perhaps because those patients, many of them were cured, and the impact was reduced in terms of prostate cancer survival. But this was a clear-cut difference in survival. Even after 3 years, they could see a difference. And I think it's logical to talk with your doctor about getting on a cholesterol pill if you have one of these more serious variants of prostate cancer. Generally speaking, the medicines are well tolerated. There is some expertise in administering them, making sure that it doesn't irritate your liver or cause muscle aches. But millions of people are taking them safely. And there are apparent advantages in men with prostate cancer, at least with certain types of prostate cancer.
So in Abstract 163, it's talking about Xgeva. Now, one of the biggest issues in an older population outside of treatment is bone loss and fractures and any issues with the bone. And so you want to make sure you keep up your bone density. And then specifically when you have metastatic lesions on the bones, especially when you're taking hormone therapies, there is Xgeva, which a lot of doctors use in order to make sure that patients can keep up their bone density and not have, fractures, and the treatments don't make it worse as far as their bones go. However, osteonecrosis of the jaw has been a known side effect of Xgeva. While it's not common, it is extremely detrimental. And so can you speak to this abstract and really the differences in dosage between two different types of Xgeva dosage in order to prevent osteonecrosis of the jaw?
Yes, this particular study actually codifies something that we've started recommending some time ago, and that is to not follow the package insert with Xgeva where they say take it every month, but to spread out the intervals between injections to maybe 3 or 4 months to try and reduce the incidence of osteonecrosis. We were just seeing too much osteonecrosis, which is a non-healing wound on your jawbone. It does slowly get better when you stop the Xgeva, but you can have teeth fall out. It can be really ugly when it happens. People taking Xgeva need to be very vigilant for any early onset, because if you catch it early and stop the Xgeva, it will heal sooner and you'll have less problems. But this particular study confirmed that getting monthly Xgeva in the group of patients that they were studying, there was a 9% incidence of osteonecrosis in the men getting monthly Xgeva. And that dropped down to around a 6% incidence of osteonecrosis in the men that took it every 3 months. It hasn't been validated that the anti-cancer effects, you mentioned the anti-osteoporosis effects of Xgeva, which are well documented and which is very useful. There's also a modest inhibitory effect on cancer growth in the bones that was demonstrated in the original trials that got Xgeva approved. Whether that is going to be maintained with these lower doses of Xgeva is uncertain. The anti-osteoporosis effect will certainly be maintained because we know that even tinier doses, the same medicine under a different name called Prolia, where they give half an Xgeva shot only every 6 months, results in good reversal of osteoporosis. So giving double dose Xgeva, double dose Prolia every 3 months or every 4 months is going to be more than enough to ensure that the osteoporosis problem is dealt with. But it's uncertain whether it will still maintain the modest anti-cancer effect that was also shown with Xgeva. These are for men who have known cancer in the bones, and there is a modest inhibitory effect on cancer growth in the bones when men take Xgeva.
So in Abstract 178, it's talking about BAT. Now, this is a very experimental treatment, Bipolar Androgen Therapy, and it's where they're basically injecting large amounts of testosterone into the body. It is experimental, and they're trying to see if they can shock the cancer and get the cancer to, retract and behave, and they want a cure rate just like anything else. Now, in a lot of the studies, they've studied against enzalutamide, so it's the idea of a lot of testosterone versus taking the testosterone out of the body with androgen deprivation therapy. So in this study, they're looking at how BAT reacted as far as cure rates go. And so can you talk about what the abstract said, and are we really seeing a benefit to this type of a therapy?
Yeah, we're looking more at response rates than cure rates because these are men with advanced metastatic hormone-resistant prostate cancer. So this means that their PSAs are going up and the cancer is growing even though they're taking Lupron, Orgovyx, or Zytiga, or Xtandi, and the disease is still progressing. So there has been interesting research showing that a minority of men in that situation, their cancer will actually start to regress if you give them testosterone. And the testosterone is given by injection once a month. The remissions are occurring in a small segment of patients, not everybody. And unfortunately, they don't tend to be that durable. Of course, men are excited. They've been deprived of testosterone many times for years, and the idea that you could actually take testosterone and possibly get a benefit is an attractive proposition. In this particular study, they looked at 50 patients. It was a multi-center study done in a very didactic and professional way. And the thing that caught my eye about this abstract was that the response rate was like 16 or 17%. Response being the historical 50% decline in PSA from baseline. So if someone went into the trial and their PSA was 100, the PSA dropped after starting the BAT down to 50 and was maintained for at least a couple months. So that's 1 out of 6 patients, 1 out of 7 patients benefited. There are and can be problems with giving testosterone. It can cause, in some men, the cancer to grow, and there can be bone pain and things like that. This needs to be administered by very professional doctors that know what they're doing and know how to monitor people very closely. Excitement about BAT, and it gets a lot of attention because testosterone gets attention, and people do feel better from a subjective point of view. A 16% response rate, it's not a 0% response rate. And if people are running out of options, and that can happen as the disease advances, maybe they've already been through Pluvicto, they've already been through chemotherapy, they've already had immune therapy. The idea of giving the bat under professional supervision is not ridiculous. If you're in the 16%, that's a big win. You get testosterone, you feel stronger, cancer regresses. But it's not something that is high on my list in terms of, oh, let's get them on bat because of these. This has been my experience as well, that only like maybe 1 out of 6 patients is going to get a nice clear-cut benefit from doing this.
As we mentioned before, we're going to go ahead and link all of the abstracts that we mentioned in this video below in the comment section. We'll include the title and the abstract number so that you can go ahead and do your own research. And we'll also link the general list of abstracts so that you can look at other abstracts that were presented at ASCO GU that we didn't get to today. Now, a couple of key things to remember when it comes to looking at abstracts that have helped me as I've researched over the years is to go ahead and, just Google the terms. You could also check out our website. We'll link the glossary on our website that can be quite helpful when it comes to this. But, they're looking at overall survival, they're looking at overall cure rates, they're looking at PSA response rates, and some of this jargon can be a little overwhelming at times. But if you take it slow and just go ahead and Google the terms, even ChatGPT is a great resource to explain abstracts. You can actually copy and paste the link in the ChatGPT bot, and it can give you a little summarized version, and you can kind of have a conversation with it on what certain terms mean. It has been a very helpful tool for a lot of prostate cancer patients, and it's really exciting that we can use these AI models to have a conversation with in order to do our clinical data research. Now, if you have any questions about your specific case, you can contact our helpline at pcri.org/helpline. These are prostate cancer patients who have had prostate cancer, but they have also gone through a lot of the therapies that we talk about on this channel, and some of which have been in these abstracts, whether that's radiation or hormone therapy and the like. And it's just a great way to get you ready for your doctor's appointments so that you can have just conversations with your doctor that are empowering you, answering your questions, and helping you know what the next steps are. Again, you can find them at pcri.org/helpline. Please remember, you're not alone. If you have questions, go ahead and put in the comment section. We'd love to answer them, and we hope you have a great week.